Hi, everyone, and welcome to the DIS COVID information sharing call for April 14th, 2020. My name is Leander Lacey, and I'm the Senior Manager of Capacity Building and Member Engagement for NCSD. We're so happy to have you all on today. I see that there's a lot of chatter in the chat box saying hello from all over the country, so I definitely want to send a warm welcome to you all for joining us today. Just some housekeeping before we move forward. In order to access the audio for today's call, you need to either have the Adobe system dial your number, which is highly recommended, or you can dial in using the information that's on the slide right in front of you to the left. You won't be able to access the meeting audio via your computer speakers or microphone, so you will have to either dial in or dial out. Once you are connected, your line will be muted in order to limit background noise and ensure clear audio for today's call. This meeting is being recorded and will be shared with all of you. Later on, there will be an opportunity to ask questions and participate in some discussion. You can either use the chat box function for that, or you can unmute your line by pressing *# on your phone. You can also use the chat feature to submit questions as they come up as the speakers are presenting, and you can also alert me or the other hosts for any technical issues that you have by using the chat function. Just a reminder that this is a weekly call that we've been doing for DIS. It's every Tuesday at this time from 3:15 to 4:15 Eastern. We'll continue to send out registration links, reminders, past recordings, and the agendas, all of the information that you need for these calls. So thanks again, you all, for joining, and I will pass it over to Brandy Roberts to go over our agenda for today.
All right, thanks, Leandria. And can y'all hear me okay?
Yes, I can hear you. Sounds good.
Yes. Okay. All right, well, thanks, everyone. Welcome again to our weekly update for our DIS and our COVID response. So I definitely want to thank you again, Leandria, and also David, the Executive Director, and also our NCSD folks for bringing this to us every week, because this has definitely been helpful for our staff. So today, just to kind of briefly go over the agenda, we're going to do a quick updates from NCSD from David Harvey and Matt Pryor, and then we're going to switch over to our DIS or SD program staff from the field, Gonzalez from the Santa Clara County Department of Public Health in California, and also Sunder, who actually is a DIS that's working with contact tracing. And then from Massachusetts Department of Public Health, Simona Lang, who will also be with us today. And just to kind of continue on the conversation from last week, we're going to go over again some contact tracing and some different perspectives from the field of DIS as we navigate the COVID response in our different particular states. So we will pose questions to after the presenters are speaking, and we will give everyone the opportunity to actually ask some questions for our presenters. So I want to go ahead and turn it over to David Harvey or Matt to go give us some NCSD updates. Thanks.
Thank you, Brandy. This is David Harvey. Leander, I just want to do a sound check. Can you hear me okay?
Yes, I can hear you. You sound good.
Okay, great. Hi, everybody. Thank you once again for joining us, and thank you in advance to our presenters who are talking today about contact tracing. A couple of updates from NCSD before I turn this over to Matt Pryor, who's going to build on some of my comments. First of all, you all know from the news coverage of COVID that contact tracing is getting discussed everywhere all the time. What is missing in the media coverage is the story of the expertise of disease investigation specialists who've been doing this work for over 40 years. What's also missing from media coverage is what it takes to effectively reach those most in need, and namely in the context of COVID and STDs, as you all already know, that is reaching marginalized communities, communities of color, low-income communities. We know that all of you and this national workforce have a very powerful story to tell about what it takes to employ effective public health strategies to reach these communities. I can assure you that we at NCSD are living, eating, and breathing this every day. We have brought aboard a media firm to try to get through on the coverage to tell this story. because the more we can tell this story, the more we can win new resources to support all of you, DIS, and broadly speaking, our field. So the fight is on, and we need your help. I am desperate for your help. We know it's very hard for local DIS to speak to the media in many situations because you're employees of health departments. But again, I think some of you probably have seen our appeals for this. We need folks to be able to talk to the media when it is needed. We need to tell the story of DIS and how DIS can reach the front lines and how DIS are already responding to the COVID emergency. So that's my great appeal to you at this moment. If you have any ideas and suggested speakers, if you yourself can speak, please be in touch with us. We need to develop an army of folks who can speak to the media. The second thing I want to acknowledge, and I think our dear colleagues at CARDIA are on the phone today, but we are doing very important work, literally as I speak, and have joined forces with ASTO to get off the ground some pilot initiatives around training for DIS and training for newly hired contact tracers, which, as you know, many states and the feds are moving forward to hire to place within state health departments and local health departments to start to really ramp up contact tracing. Contact tracing is the key to reopening the economy, coupled with rapid testing. And so there is a huge, massive scramble underway to figure out how to support newly hired contact tracers that are going to be coming into the field. Right now, we know a lot of these hires are happening under emergency preparedness. The big plug that we want to give to all of you is that we hope you'll ask questions of your colleagues in health departments about the role you can help play in supporting, mentoring, supervising, guiding these new hires. We are very hopeful these new hires will ultimately come back to the STD field in the future. So I'm really appreciative of our team's efforts around this. We love our colleagues at CARDIA. We're doing very hard work to get some initial training materials up and running with our partner ASTO, and so look for more updates about that as we get forward. There's an awful lot going on around these two areas of work that I just mentioned. Last but not least, for those of you who are reading if you're not signed up or if you're not plugged into receiving the STD Weekly or our COVID news alerts that come out every other day, please do so. Please be in touch. We want to make sure you're getting our information. We are appearing, and there are some important media stories that have come out where we're starting to kind of break through with our messaging. So pay attention and pay attention to those media articles. They're very important things that you can use locally to make the case for your own role in this work. Without further ado, let me turn it over to Matt Pryor. Thank you all very much.
Thank you, David. And yeah, just to, I think David covered most of our communications efforts, which are ongoing right now. We do, and we continue to update our COVID Command Center for STD programs, STD clinics, and DIS. So please do visit that page and check out the resources that are available there. If you do have any resources that you can share, please send them on over to me at mpryor@ncsddc.org. I can put my information in the chat box. And again, just to echo David's sentiment about, we're hoping to create a speakers bureau of DIS from around the country who are able to speak to the media. And again, we do understand that it's easier said than done, especially for those of you who are working in public health programs, which are most of you. But you have a story to tell. Our DIS around the country have a story to tell, and we've been increasingly getting requests from media contacts to talk to DIS who are on the ground doing the work of COVID response and STD response. So, I would encourage you to check with your supervisors, to check with whoever you need to, and please do reach out to me at mpryor@ncsddc.org, and we can take it from there. But I do appreciate all of the work that all of you are doing every day, and we are here to help you. So thank you, and I guess I can turn it back over to Leandra.
Thanks so much, David and Matt, for those updates from NCSD. As far as being interested in speaking, Matt mentioned that Speakers Bureau, you can definitely email him, like you said, at mpryor@ncsddc.org, or you can email me directly, and I will get you to the right person. Thank you so much. So now we'll move into our perspectives from the field. Like Brandy mentioned, we're continuing our discussion around contact tracing. There's so much press and so much news around the importance of contact tracing during this time with COVID response, and we know that DIS really holds this special skill set. So I'm so excited to welcome first from the Santa Clara County Department of Public Health in California, Gonzalo Ricombini and Sundar Batalia, and then we'll have Simona Lang from the Massachusetts Department of Public Health speak. So I will go ahead and hand it over to Gonzalo to speak first.
Hello, can everybody hear me?
Yep, we can hear you.
Hi. First, I want to just hope that everybody is out there safe and healthy, and thanks for doing everything we're doing. So, from my perspective, I just want to give a little bit of background in Santa Clara County, given that we were one of the first counties to implement the shelter-in-place in the U.S. Just kind of like our experience, what we went through, and then Sundar worked more in contact tracing, so he can talk more about that and more in detail about what we did here in the beginning of the outbreak, and possibly what the plan is for the future. So we had our first COVID-19 case confirmed in Santa Clara County in January 31st. Our county had immediately opened the Medical Health Joint Operations Center, which is our emergency response. And here in Santa Clara County, the DIS are called CDIs, or Communicable Disease Investigators. As all of you know or experience, we are having an increase in syphilis, especially amongst the homeless population, and that is one of the specialties that we have, is to do interviews and to obtain contacts for syphilis amongst the most marginalized of our community. And I think, like we were saying earlier, that's going to be the biggest issue as far as contact tracing goes, working with these communities. And we have the DIS, CDIs, we have a vast amount of experience in getting contact and interviewing and locating these clients. So I think that's one skill set that definitely needs to be mentioned if we do talk to the media about our experience working with these marginalized communities. So we had our first case back in January 31st, and we got Sundar and another one of our coworkers to go and work at the center, answer doctors' phone calls and all that. As far as all that goes into detail, Sundar will talk about that. How this has affected our services, we haven't been going to the jails, and we haven't been doing field visits for about over a month. We had to close down our screening clinic, our STD HIV screening clinic, the Crane Center. We haven't been seeing clients there. Our STD clinic has first started seeing just syphilis-related clients for treatment and DIS referrals. Everything else, is, as far as prep, we've been doing it over the phone, and people can still come to our pharmacy. The TB clinic is still open, but on very limited basis, and everybody has to wear masks. In the health department, the CDIs have been used for helping to screen people at the front, doing temperature checks, just asking just general questions about people going in. And as far as the biggest thing is that now we are pretty much either working from home or helping out with inputting data into the system, the electronic reporting system we use, CalReady. Since we're using the same system to put in the details for COVID-19 patients, They've used us and our HSRs, which is our like clerical workers. They use the CloudReady system too, so they've been called in to help with inputting information from the reports from the hospital to then report it to the state and the CDC. And yeah, that's pretty much how it's affected our services. Not going to the jails, it hurts us because a lot of our new clients, especially the females of childbearing age and their contacts, given the situation, we do need to do field visits. We do need to do jail visits and interviews. So that has, has affected our services. And yeah, Sundar, can you hear me, or can you talk, Sundar?
Yes, I can take it from there. Thank you, Gonzalo.
Okay.
So we actually started our Medical and Health Joint Operations Center, is what they're called, MHJOC, in the beginning of the week of the last week of January, and that was before we even had our first case. So when we were setting this up, like everything was very rapidly evolving. We had different departments. We had like planning, logistics, communication, technical documentation department. The folks from sheriff's office were there. The fire department folks were there. And then we actually work on the operations department, which was led by our STD HIV controller. And what we were told in the beginning is like the environment that we'll be working on is going to be very different from our like a regular environment, because this is going to be more militaristic, and there's going to be a lot of orders, and so that was made clear in the very beginning, like not because we're very laid back as far as how we treat each other in this county, and we respect each other, and there's a value of just culture, and sometimes like directly ordering folks isn't really it's not normal in normal situations, but this was different. So that was made clear from the very beginning to everyone that was involved in the operations center. And we set up some phone lines for providers and the public, so we fielded questions from providers. So the folks would go into their clinics, to get it checked out, because people already had some information about what kind of symptoms that they should be looking at. So when they had, cough or fever, they would go to doctors, and the doctors would call us. It's like, hey, these are the symptoms that my patients have. Do they qualify for testing? And at the time, the definition of PUI, the persons under investigation, who are the ones that are qualified for testing, was very narrow. The CDC had put a very narrow definition of folks that had to have been to Hubei province in China. That is the province where Wuhan is, and they should have had at least one of the symptoms, either cough or fever, and only then they're qualified for testing. So each patient's case was reviewed by health officer. We actually came up with our own persons under investigation form that included the fields from CDC form, and we added some stuff that was appropriate for our local health department, because we wanted to capture the living situation of all these individuals. What are their health conditions? If they're immunocompromised, who are in their household? If they do turn out to be positive, then we can take appropriate actions immediately and not have to wait around for those necessary information later on. So we're very thankful that our leaders kind of foresee what was going to happen to some degree. Then when we had our first case, DIS were used to do a chart review for this patient immediately and gather all the information for the health officer, so she's educated on the patient and the case, and so that she can provide correct information to the general public and the press. And after we had our first case, it was like all hands on deck, and there were more people who came into the center, and policy folks were writing policies to get some more resources in there. And DIS and former DIS were used to do contact tracing at that time. So when we had our first case, we contacted their family members, we contacted the healthcare providers that they went to see, and the folks that were at the clinic. We called every one of them just for the symptoms. We ordered quarantine and isolation letters. Whatever was appropriate quarantine is for folks that do not have symptoms, and isolation for folks that do have symptoms. And then after that, we quarantined them and isolated them. We had a bunch of nurses and DIS checking in and monitoring for symptoms every day, and we used the CDC's form for monitoring for symptoms for those folks. So that was the first couple of weeks at the center, and that's when I worked there. When we had the third case and when we knew that there was a community spread and the things kind of, I think, changed, I don't really know what is the contact tracing like. I know for a fact that we're still doing contact tracing in healthcare settings, and we're still doing contact tracing for their household members. But beyond that, I'm not sure what kind of contact tracing is being done. It's kind of nice that like most people are at home and not out and about, so there's probably minimizes of the contacts right now. So that's helped. As far as future plan, I don't know what the future plan is but I think there's going to have to be some level of contact tracing. And I heard the World Health Organization's Dr. Mike Ryan referred to DISs and CDIs as the cluster busters. So that's going to, I think, catch on. So the folks who you're working with media, they probably should just focus on this, because this is catchy and kind of public health meets pop. We kind of, it's kind of cool phrase for CDIs and DIS, I think. So there's going to have to be a lot of cluster busters working on this to get back to normal in the next year or so. So I'm hoping that would be one of the strategies nationwide to get back. So I'm happy to answer any of the questions if anybody has any questions.
Great. Thank you to both of you. Just hearing that perspective from your county in California is super insightful. So we'll now pass it over to Simona Lang from Massachusetts.
Hi, good afternoon. My name is Simona, she, her pronouns, and I'm a field epidemiologist, which is like a DIS, here at the Massachusetts Department of Public Health. I'm sorry to have missed previous iterations of this call, but I'm so grateful to NCSD and for our community for the opportunities to come together virtually at this time to connect and share learnings across jurisdictions. And I wanted to make sure as well that if you haven't already heard it today or enough, you're all doing important work in increasingly challenging times, and it is so appreciated. And we're doing it, we're in it. So just wanted to make sure that everyone felt appreciated today. A little background about where we stand in Massachusetts. Today, as of last night, we have 26,867 cases, 844 deaths, and 122,000 tests that have been done. 30% of our tests are coming back positive for COVID-19. Our case fatality rate is below the national average, but our hospitalizations are increasing, and based on current models, we're sort of in what we anticipate to be our peak from April 10th to April 20th of hospitalizations. So some of the field epidemiologists or DIS in the Division of STD Prevention have been now pulled into COVID follow-up. We weren't at the forefront like it sounds like was happening in other jurisdictions, but we have been pulled into contact tracing as well as some other roles. While many other members of our team are still doing routine STI and HIV follow-up. I think it became pretty clear that our skills and expertise in terms of interviewing and patient engagement and partner elicitation, make us really able to take on this work quickly. And I think that our ability to onboard into the COVID follow-up has been really successful, despite having some challenges that we're all facing in a time where there's, lots of things happening at the last minute and new policies coming out every day. I wanted to mention that although we have attempted to shift workload off of people who and on our team that are doing COVID follow-up, we still have our HIV and STI caseload and workloads, and trying to shift that has been an interesting process. Those of us who are taking on COVID cases like myself have been attempting to close out other cases, syphilis and otherwise, and redistributing some of those interviews to other folks on our team. But something that we have here in Massachusetts is outposting at different hospitals and some of the major clinics. And so we do have a relationship and access to the medical records through EMRs and other mechanisms that make it really important for us to maintain those relationships. So while I am working COVID cases, I am also one of the outposted folks at a community health center. So I'm still getting cases and outreach from the, of course, smaller amount of people still getting tested at this time. I'm sure one thing folks have heard about Massachusetts are two big collaborations regarding contact tracing at this time. So one is we have a relationship with a number of public health schools and students who are working on some of the contact tracing and other mechanisms, and also about the CTC, the Community Tracing Collaborative, which you may have heard from our Governor Baker, is an initiative with Partners in Health to increase our capacity for contact tracing by hiring a number of folks to be trained to do this work. And they're still working out all the technical details of what that will look like, and each of those initiatives is using a different system than our usual surveillance system, which we use Maven here in Massachusetts. So the students who are volunteering to do some of that contact tracing are using RedCap, and then the Partners in Health collaborative folks are going to be, I believe, using a cloud-based CRM, I believe Salesforce. So, thinking about how we interact and how we bring all those data back to a place where we can all know what's going on at any given time will continue to be a challenge, but we're excited to see some additional capacity. And, again, sort of echoing what David said earlier about how what does this mean? What does bringing in other folks and needing to train them mean for our work, and the fact that we do have significant expertise in this area that doesn't come just from a quick overnight or online module. We acknowledge that it's really necessary to bring in more capacity based on, we're facing a decade of erosion of public health workforce and infrastructure across many states and jurisdictions. So we need the help, and we need to be prioritizing our work that we do day in and day out for the rest of the time as well. And, curious to see what will the impact be on the role of the DIS moving forward from here. So, so I mentioned that some of the challenges we're finding is with communication and coordination around cases and case assignments, especially with folks at the local board of health level and different levels of Maven use of our surveillance system. And it has shown me and made me very grateful for the systems that we have set up in STD in order to be able to monitor, equitable distribution of caseloads and having clear responsibilities. So I think that it's showing the different ways that we have actually set ourselves up for success in our general normal STI work. some of the key learnings that have come out of doing contact tracing are really some interesting similarities and differences between doing an interview to find syphilis partners versus COVID contacts. And you know, some of the main differences are really in how that interaction goes and in terms of responsiveness. So I've found that the COVID patients that I'm speaking with are quite responsive. People are very much at the ready with their phones, should they still be well enough to do so, and are very open to discussing their symptoms, their other health information, their employment situation, and things like that. And the elicitation of partners has been relatively smooth in comparison to the sometimes difficult task of eliciting partners for a newly diagnosed HIV patient or someone with syphilis. And so I think it's an interesting comparison to look at those two things and to think about the role that stigma plays in our routine STI and HIV case follow-up, and just to consider what that still looks like in COVID, just maybe manifesting a little bit differently. Something that's been really similar in the follow-up is thinking about what our role is in terms of being that connection to a patient or to a contact. A lot of the folks we're speaking with are really confused or really need some questions answered, and they haven't been able to do that with all of their the burden on the health system and the doctors and nurses and other providers. And that's true. We've found that to be true for our HIV and syphilis patients as well. When the average provider only has 10 minutes with a patient, that's where the DIS really takes up an important role in doing that disease education and the crucial risk reduction counseling. And, you know, it becomes our role as, you know, a subject matter expert, which is a very important thing for us to be doing. And what this whole process has really brought to me is a lot of questions and some insights around you know, this role and what we can do moving forward. And some of the big questions that I maybe can leave us with today is, you know, how seeing this global pandemic unfolding and, you know, people are reading about it, learning about it, will this newfound awareness about what public health follow-up looks like impact our routine STI and HIV work, and how will that make people more aware or more willing to engage with us in the future? I have curiosity around the more visible fractures in our healthcare systems that are really coming to the fore. Now that they've been laid bare, will they be remedied, and will that impact our ability to help support our STI follow-up work as well? And out of curiosity, will social distancing contribute to meaningful disruptions in transmission of STIs and HIV at this time? Or will we see exacerbation of ongoing disparities, just the same way that we know that inequitable distribution of resources and different types of marginalization contribute to both high rates of STIs and high rates of COVID in certain communities? Thank you so much.
All right, great. Thank you, Simona, for that information. So I guess we'll go ahead and open up the line for questions. So do we have anyone that wants to start us off with questions, and then we'll go to the chat box if we don't have any questions on the line. So you'll press *# to unmute your phone. Okay, so I'll go ahead and start with the first question from the chat. So this is from Janelle Miller. So is anyone using the tellyourpartner.org COVID overlay in their mass contact monitoring notification, and any concerns regarding security and surveillance limitations? So any of the speakers, you're welcome to respond.
Yeah, we have not been using here in Santa Cruz County, as far as I know.
Yeah, we have not been using any of those websites.
Okay. And yeah, we haven't been utilizing that either. Okay. So let me go down to some more questions. Okay, so Gonzalo, this is a question for you, and maybe Sundar, you may be able to answer this as well. I know that you may have been answering these on the chat as well, but I'm going to go ahead and say them out loud. So what have been some of your challenges with conducting contact tracing out of the field?
So I laid out a couple of points there. So one of the challenges in the beginning was since we were only focusing on folks who traveled from China at the time, there were a lot of folks that lived in China that were visiting their families here or just visiting in general. So there was some language barrier, but we live in a very diverse county, so we have a lot of Asian American folks living here, and our workforce is very representative of what our county looks like. So we were able to recruit GIS or CDIs that could speak Mandarin or Cantonese or any language, and we have a really good language line as well. If we do not have any certain languages available, we could always do a call-in, and then we have a translator available at any time. So that helped. The other challenge was some of the travelers were here temporarily, and they were staying at hotels. So by the time we were trying to reach out to them at the hotels, they had already left, and so we had to figure out a way to find their contact numbers in their home countries. So we made phone calls in Japan, and we had to make multiple attempts to get in touch with folks in there as well. So that kind of added some challenge. The other one was we had a person who lived in their car, but he was a healthcare worker that was exposed to it. So we had to find a place for him to quarantine in place. So we already have this agreement with some hotels around here that we try to put TV patients sometimes. So we use our existing relationship to put them in the hotel rooms and provided food in the meantime as well. So we had some challenges, but we had enough resources and relationships and cooperation that we were able to tackle that initially. But when we had our second case, this person had traveled from abroad, and there were also contacts in the plane. So it took us a little bit to get the list of the passengers on the plane from the state. And since everything was so evolving and we're trying to set everything up at the same time, it took us a few days before we reached out to the airplane contacts. So we lost some of the time there. But yeah, those are the main challenges in the beginning.
Yeah, I would agree. This is Simona, that the language barriers were initially a challenge. Many of us speak one or two languages, and we're trying to reach folks with many languages. But we have been able to use resources that we've already set up in order to access language line interpretation. I think another element that's been challenging for contact tracing is really just a differential in who people's household contacts are and how well they know those people, as well as their work contacts. And I think that there's definitely a racial and class divide around how many people live in your house and how you know them and how comfortable you are talking with them and about health matters with them. And so that has been something that has come up. as well as people feeling comfortable or uncomfortable discussing their employment information, especially folks who may be undocumented or may be employed in a way that they don't want to jeopardize that. So definitely dealing with the things we deal with on a daily basis around the way that our society is structured.
Okay, perfect. Was there somebody else saying anything? Okay. I think it was just some background noise. So thank you so much. So the next questions that we had on there was regarding the homeless population from Jessica, but I believe we've had some individuals that have responded to that already. So some are being quarantined or isolated in hotels and motels. So Carlita Cummings. And we had other individuals who talked about Hotel Sandar. I think you responded to that as well. So is there any other feedback as far as dealing with your homeless population that anyone would like to add?
Just pretty much just keeping an eye out on the shelters because, just like the nursing homes are like a paradise for the virus to spread, the shelters, the same thing. So it's about making sure that, if there is, one person that tests positive or has some symptoms in the shelters, that we move quickly to isolate them.
Okay, I would bet. Sure. Okay. All right. So for the next question we have from Shanika Wilkinson. So have we had any health departments that have any issues with implementing telehealth or telemedicine? And if not, what successes have you all had? And that will kind of be in relation to contact tracing.
I have to say I've been pretty surprised at the smooth transition to teleworking that's happened at our health department, and I think that it's clear what the priorities are, and the only thing is that there are some elements to our work that are inaccessible when we move to telework. And I've actually been someone that's still in the office, and that's because we do need access to certain things like fax machines for confidential information. And, access to drives that might contain confidential information that can't be taken, offsite or uploaded in a cloud database. So, I think there are definitely issues that we, particularly in STD and HIV, confront when working offsite. But I've been pretty impressed with the ways that we've set ourselves up for success by having cell phones and laptops and the ability to do our work remotely.
Okay, thanks so much. Anything you want to add? Go ahead.
Oh, sorry. I'll let our Santa Clara folks add in, and I had a follow-up question to that.
Okay.
So, go ahead, Sarah.
Well, I was so we have STD clinic in addition to STD screening clinic at the health department, and we're still keeping, like Gonzalo said earlier, we're still keeping the appointments for PrEP and for syphilis treatment and syphilis referral from DISs. So our PrEP navigator has been working with the PrEP patients over the phone, and for the folks that need PrEP, and they're able to get it. I know it's not the same as in-person meeting and going over things, but it has worked. They're able to still get the medication, so there isn't that much of a challenge. I think it has been pretty seamless transition in that regard.
Great, thanks.
And
this is Leander. Sorry. Go ahead.
No, sorry. As far as with telemedicine that I've noticed, just my other investigations for HIV and syphilis. As far as the telemedicine, the biggest issue I think continues to be lack of testing availability. A lot of people that, they get screened for coronavirus, as far over the phone and with telemedicine, but the providers right now can't really do much, I can see, from what I can see, other than to recommend, quarantining themselves or isolating. But I think that the biggest challenge with anything with telemedicine or this response in general and the follow-up to the surge is the testing.
Thanks for that, and sorry for cutting you all off earlier. My follow-up question around telehealth was this around confidentiality. Something that has come up in past calls is if people are using telehealth and telemedicine, how are they ensuring the confidentiality of patients? So I wanted to ask for our presenters and anyone on the call, for those that are using telehealth for contact tracing, how are you all ensuring confidentiality of clients? Are you using specific platforms? Do you all have protocols in place from your health department that you follow? What does that process look like to make sure that information stays confidential? A lot of DIS, I know, working from home, working remotely now, too, that adds another layer to it.
I would think it's the same, like, as far as giving out results, verify the full name, the date of birth, ask if, let them know, hey, we have some medical information to go over. Is this a good time? Are you somewhere where you feel safe talking about it, or somewhere in private? Just basically, the same way, as far as for me, I would think it's the same as giving out results, as far as STDs go. So it's pretty much just verifying full name and date of birth and making sure that they understand that you're going to talk about some health-related issues, and if they're okay to talk about that at the time, or maybe is there a better time to call? Do you want to call me back? Or, just making sure that they're comfortable with that, making sure that, if you're not on speaker. I think from the provider or our perspective is, making sure that you're in a place and isolated from anybody, that you don't have the person on speaker talking about this and you have family members or friends around. So it's just being mindful of that and respecting the other person's confidentiality.
Okay, great. Leandra, did you have anything else to add as far as the telemedicine?
That was it. Thank you.
Okay, good. Okay, and I see where some individuals have responded as far as the processes that they're doing. So pretty much, with us in Arkansas, we have not utilized telemedicine as far as our STD clinics, but I know some of our private providers have been using telemedicine, and that was pretty much situations that they already had up and running before COVID, so not really any issues with that. But as far as like our local health department, they actually just closed, so we're not utilizing any type of telemedicine here as well. So thanks for the information. So for our next question, and this is a really good question that I'm interested in hearing some feedback on. So sometimes when so Marissa said, sometimes when you notify a client of a likely STD exposure, they think it's a joke or a mistake. Do any of you run into this when following up with contact, or was everyone receptive?
Marissa, that is so true when you're talking to a contact. And that has never happened to me in the process of doing contact tracing for COVID. And I think that's because, one, people are very engaged with what's happening. This is happening to so many people and so many communities that people are aware, and people are scared, and they're hearing from someone in an official capacity and are much more likely to believe what's happening. And I think there's definitely a trust there that doesn't always show up when we're doing our STD follow-up. And so I think people are willing to believe it. I think people are really hungry for information, and they're not always getting it from, from the news and our politicians, of course. And so they are grateful, actually, to be getting a call from someone at the health department in order to talk about, what their fears are and what their questions are.
Maria, I guess to kind of add to that, because I know this is one of the questions that came up here in our end, because our DIS actually just started with contact tracing, and I was doing the training today. So kind of on the same lines of that, what about scams? Because I know we have been seeing some scams in relation to people with contact tracing. So have you run into people not believing that this is the health department actually contacting them for the COVID contact tracing?
So I have heard about scams, and I know that there's a lot of people trying to take advantage of this situation, which makes things harder. But I haven't heard from any patients or contacts that I've reached out to about their concerns for scams. I think one of the things that we often will do when we're doing STD follow-up that would definitely apply here is to give that person our office number and or our supervisor's number and say, well, if you're concerned about if I am who I say I am, please call this number. You can verify my identity. One of my colleagues, Sarah, just put in the chat that we can take a picture of our business cards and text that to them. We do a lot of texting, and I think that definitely reaches people.
Okay, good point. And I think Sarah just mentioned that as well, as far as using taking a picture of the business card. That's actually a good idea as far as, just so they can identify if that's a person from the health department. I know that came up for us. Okay, so do we have any more questions? Okay, so Casey, you do the business card as well. Okay. All right, so another question that has just came up from Adrian, thank you. So any suggestions for DIS doing PUI case report forms and must contact a private doctor or hospital to complete the form? And how are DIS handling the HIPAA requirement regarding release forms?
I think most jurisdictions at this point have declared a public health emergency, and I think most doctors and hospitals are really aware of the importance of the public health follow-up that we're doing. And so we haven't gotten any pushback at all about release of information. That may not be true for the folks that you're contacting. One of the tools that we have at the ready here in Massachusetts is a letter that indicates, which statute says we have access to which information. And so it's sort of a form letter that we can offer to fax. And that usually gets around any problems. But in terms of COVID follow-up, it's really been a breath of fresh air in terms of lack of resistance to our work, whereas sometimes we get pushback from providers that, for HIV or syphilis, for example. And in this case, I think people are really invested in what's happening and being part of how we collectively get through this, that I haven't really received any pushback from asking for the information that we need to complete our follow-up.
Okay, great. Gonzalo, did you want to add anything?
Well, over here in Santa Clara County, like Simona was saying, we have our what's called Title 17 letter, which it indicates from the governor's office, just indicates, like public health investigations and, our authority and being able to acquire, bypass HIPAA in a way to acquire information to facilitate our investigation. So we have that in place.
Thank you so much to both of you. I had a follow-up question. I see if there aren't others in the chat box right now. So this is actually specifically for Simona. I know that you talked about how increasing capacity for contact tracing is really important right now, and what's going on right now in Massachusetts with contact tracing and the expanding of that capacity with the collaboration with Partners in Health. I wanted to ask, with that organization and just with increasing capacity in general, and bringing people on board that may not necessarily have DIS experience, that will be learning how to do this contact tracing, what has been the collaboration, been like with DIS in Massachusetts? Are you all at the table when, decisions are being decided about who will be trained and how they will be trained? I'm just wondering how that communication has been, because DIS do hold this special skill set. So how has that worked there?
Yeah, it's a great question. And yeah, I think we all have some concerns about what that training is going to look like, and how folks who are not experienced and don't necessarily have the expertise in this area are going to be able to do this work. And unfortunately, there's been a lot of issues in terms of getting that off the ground, in terms of what our collaboration, what our role actually looks like. And we haven't yet had an opportunity to be part of the conversation on training for those folks. And we would hope that we could be tapped for our expertise in this area, knowing that this is something we are heavily invested in, and that we have years and years and years of experience doing. But the issue is that the initiative with Partners in Health, the Community Tracing Collaborative, is actually being held outside of DPH. It's just an unfortunate element of which parts are holding which work, and we have not yet had that opportunity. And I think it's really important for us, as we were saying earlier in this call, to be able to make clear that this is our area of expertise. This is something that we have many years of experience doing, and that we should be tapped to consult on that process. And we'll have to see how that collaboration moves forward, but right now it has been minimal.
Thank you so much for that insight. I was definitely wondering, how the communication and collaboration has gone so far, and I know it's still pretty early in the game, so also hoping that the collaboration and partnership, increases between the people brought on board and DIS that have been doing it for a while. So, yeah, thank you so much for that. And with that, I want to send another special thank you to Simona over at the Massachusetts Department of Public Health, as well as both of our speakers, Sundar and Gonzalo, from the Santa Clara County Department of Public Health in California. Your insight is super valuable here. And as these calls continue weekly, we'll have a rotation of 1 to 3 DIS voices on these calls talking about a specific topic. So if any of you on the call now have an interest in speaking about what's going on in your jurisdiction, please feel free to shoot me an email. My email is here listed on the slide. There's also some links that I want to draw your attention to in the web links box underneath the slide. You'll see that there's first a DIS redeployment survey. So NCSD has been sending out this survey to DIS all over the country, getting an idea of how DIS are being reassigned for COVID response and how it's impacting their STD and HIV services. We've been promoting this survey every week via our emails and through this call. So even if you have taken the survey, I encourage you to take it again, please, if there are updates from your area. And we're keeping track of that and using it to inform a lot of our programming that we're doing and supporting our members. There's also the NCSD COVID Command Center. There's a ton of resources on the COVID Command Center. I truly encourage you to check this site out and peruse it, see what resources are available there. Our communications team has been hard at work with keeping this up to date for you all, so we'd really love it if you took advantage of that. And then the last thing is the DIS Slack workspace. This is just a space where you all can continue this conversation, where you can chat with one another, share resources, share ideas, share best practices, share challenges and success stories, anything that you'd like there, and connect with other DIS around the country and DIS supervisors. So that link is there. I know Tiffany has also put the Slack link as well as the survey links that I mentioned earlier in the chat box. So please take advantage of those. And there are a host of other links here as well in the web links box with other resources such as the contact tracing from Washington State and a Dear Colleague letter from the Division of STD Prevention at CDC with STD treatment guidelines. All of these resources are also listed on the Command Center. So again, I encourage you to check that out. And with that, I want to say thank you to Brandy for facilitating with me, again, to our speakers today. And thank you all for joining. I hope you stay safe and healthy, and I will talk to you all next week. Take care, everyone.
Bye. Thank you.
Bye.